Hi, I'm Dr. Stephen Ellis. I'm a thoracic radiologist and clinical lead at the Diagnostic Imaging Department at St Bartholomew's Hospital. We have a large range of research studies being performed within and outside the department, many of which have imaging as their primary endpoint. And I'd like to take this opportunity to take you through the ins and outs of radiology research reporting, because it's not quite as simple as it may seem at first sight. We use a RECIST reporting, which is set out a way of measuring bulky lesions, and in simplest terms you identify up to 5 target lesions with a single measurement. You do a sum of the measurements, and as that sum changes, if it increases by 20% or more, it's progressive disease, and if it decreases by 30% or more, it's partial response, and obviously disappearance of the lesions would be complete response. But it's not quite as straightforward as it may seem, as there are quite a few rules that go along with that RECIST reporting. For example, you can only pick 2 lesions from any one organ, and in this respect, paired organs like the lungs and kidneys and adrenals would count as a single organ. In addition, the lymphatics as a whole are considered a single organ. So quite often you will have lesions that you can't actually include in your target lesions, and then they are included as non-measurable lesions, and they aren't actually measured but can still contribute to the overall determination of whether that's progressive disease or partial response. It's also not always straightforward which measurement you should take. You should look at the lesion in advance and try and predict where the measurement you're taking is going to change as the lesion shrinks or increases in size. So ideally you should take the largest measurement you can, but particularly pick the margins that you think will still be identifiable as the lesion changes in size. And here's an example. In this simple example, the boundaries of this lesion can reasonably be expected to be identified regardless of whether the lesion increases or decreases in size. We should note that for target lesions, they have to be greater than 1 centimetre or greater in size, and for lymph nodes actually greater than 1.5 centimetres in short axis, even though pathologically in clinical terms a lymph node greater than 1 centimetre in short axis is considered pathological. As I mentioned before, there are non-measurable lesions that couldn't be included as targets. They can contribute to whether or not there's been partial response or progressive disease, but if a non-measurable lesion is to be considered an indicator of progressive disease, it has to be an unequivocal progression, so there is a slight grey area where you can determine whether or not the non-measurable disease does actually represent progressive disease. In this example, the target lesion actually decreased in size by 20%, but there were numerous other metastatic deposits identified as non-measurable disease throughout the lungs, all of which had increased in size. Therefore, overall, there was an unequivocal progression based on the non-measurable disease. The development of new sites of disease obviously indicates progressive disease, and it all seems fairly straightforward, but there are further caveats. For example, in this target lesion has actually increased in size by 20%, and it certainly looks bulkier, but in order for it to be a true progression by RECIST criteria, the absolute change in size has to be 5 millimetres or greater. In this case, an increase in 4 millimetres is insufficient, so this remains stable disease. When making a comparison on serial imaging, it is important to establish which previous measurement you're actually using for that comparison. Obviously that would be the baseline, but if the measurement actually decreases, you're generating potential new nadirs against which further increase in size would have to be compared, as well as against the baseline. And actually it is the measurement against the nadir which will decide whether or not there's been progressive disease. This is a snapshot of data entries for a study recording individual measurements over sequential examinations. I find this form of record is essential for maintaining accuracy in RECIST reporting. The green denotes partial response, generating a new baseline for comparison. The red represents progressive disease. You can see that in this instance there has been a further reduction in measurement following a partial response, but then the measurement is increasing, generating a nadir for subsequent evaluation of percentage change in size. Now it gets more interesting or complicated depending on your point of view. With the new immunotherapies, it is not unusual for a tumour bulk to actually increase despite a response to therapy because it is actually reacting to the body's ability to fight it. We get similar appearances in treating TB and fungal disease. As a result, the RECIST criteria have been modified to allow for this. In the modified RECIST, new lesions are thought to potentially have been generated because of this immune response, and therefore rather than automatically indicating progressive disease, they're added as targets. In terms of non-measurable disease, that can only contribute to the assessment on modified RECIST if there's complete response, and not in progressive disease at all. So the only way to progress in the modified RECIST regime is to actually have a 20% increase or more in the identified targets. In this example, the patient has developed a right hilar mass, left hilar adenopathy, numerous new pulmonary metastatic lesions, and bilateral pleural effusions since the nadir scan. But by modified RECIST, this remains stable disease, and the hilar mass is merely added as a target, and therefore will contribute to a possible progression at the next visit if it continues to grow. It may have occurred to you that this introduction of modified RECIST potentially generates nadir measurements that are not contemporaneous, where new targets are added at a different point in time. In this scenario, you can imagine how vital it is to have a good pictorial spreadsheet record of all your measurements, so you can actually identify the correct nadir measurement. Anyway, that's all I have time for. I to give you a taster of how complicated RECIST reporting can be, and hopefully you can appreciate that it is actually a time-consuming process and difficult, but very rewarding to do appropriately. Thank you for watching.